give you some information regarding the Straumann PURE systems. We've been working with the systems, with the ceramic system for more than 10 years now. We started in 2010, 2011 with the monotype implants. It was not really on the market in those days, but we already had the chance to work with it for a couple of years. And then later on, we started to work with the two-piece implant around about in 2015. And this year, I need the presentation. Thank you. And this year, we just finished our clinical investigation regarding the monotype implant, the 10 years data. The first half of the patients have already been investigated, and the second and the third center, they are still investigating the rest of the patients. So hopefully in a couple of weeks we will have 10 years data on the monotype Straumann PURE implant system. So this is already something in terms of long-term performance regarding ceramic implants. And yeah, so today we splitted it a little bit, since Andre will do the surgery tomorrow, since this is his hometown. He is the local here. And I would just give you a short introduction on the components that the system has, show you some short videos how I work with it, but I then will shift over to Andre, who shows you some further images of the clinical case he is going to treat tomorrow, and also give you some information of he works with the Straumann PURE system. So I told you before, we have two different implant designs when we talk about the PURE system. We have a monotype one-piece implant, and we have a two-piece implant design. So let's start with a monotype one-piece implant design. What's special regarding this design? Of course, the implant body is directly connected with the implant abutment. So of course, we have, in terms of the prosthetic reconstructions, we have some possibilities to make some corrections, but of course the possibilities are limited. And for that purpose, it's absolutely necessary, we've heard it several times today, that we perform a so-called prosthetically driven implant placement. So do a backward planning. We've seen many images today. Take a look at the radiograph, and then choose the correct prosthetically driven implant position before you do the surgery. But by the way, this is nothing that is something specific for the monotype implant. You should do it in any case, especially when you start. You have to do an adequate planning. This is the most important step. How you transfer the planning into the surgical situation is something different. You can use guides, you can do it conventionally, and nowadays we talk a lot about the fully guided procedures, the half-guided procedures. In my opinion, it's a good additional tool for an experienced clinician. It's nothing that prevents you from making mistakes. It gives you more security. But any clinician should be able to handle a clinical situation also without a fully guided setup, because your guide can break during surgery. You noticed that the implant position is not correct. Every one of us who does surgeries like this will have noticed that not always it's the correct position. So you have to be able to make a correction during the surgery, and so it is necessary to, in every case, to do an adequate planning. What's also specific for the monotype implants, if we do not want to perform an immediate implant loading or early loading, especially in completely edentulous cases, this is sometimes a challenge. We have to avoid the unwanted overloading. This is something difficult, or more difficult in terms of the monotype implant, since the abutment penetrates through the peri-implant soft tissues, and this is not a big deal in terms of a single implant, a single tooth gap, but the more implants you place, larger edentulous areas, and especially completely fully edentulous cases, this could be a challenge to avoid the implant overloading. And in cases like this, it's also very important to talk to the patient. He always is the co-therapeut. He has to know what type of implant he has, and he has to be aware of the fact that if the bone is too soft, he should not make an overloading or use the abutment as something to chew on. Regarding monotype implants, it's only possible to have a cement-retained prosthetic reconstruction. So it's, of course, with the monotype implants, it's not possible to have a screw or reversibly screw-retained implant connections, and cementation processes in my opinion, it's a good thing to do. We also have problems in terms of the screw retentions, but of course, cementation processes are more, the chance that you make mistakes are higher, because if you use too much cement and if the implant shoulder is a little bit too deep, the chance that you press the cement into the surrounding peri-implant mucosa is pretty high. And for that perfect purpose, we need defined cementation protocols for the installation or the placement of the crown. We know from survival or from meta-analysis that regarding the monotype implants, the clinical data is pretty safe. So we know that the investigated monotype implants show similar 1 and 2 year survival rates compared to published data on titanium implants. So what's the design of the monotype pure implant? Of course, it's a tissue level design, which means we have an intraosseous part that's in the bone tissue. We have a machined, polished transmucosal implant shoulder, and this shoulder has a height of 1.8 millimeters. So if you work already with the titanium Straumann implant system, you know that this is the standard plus implant neck, which is a established implant design from Straumann. And we have a fixed abutment on the implant body itself. And this abutment has 2 different heights. We have 4.0 and 4.5 millimeters. So you have some sort of flexibility in terms of, the interocclusal distance when you place the implant. This is something very special. If you're insecure, also the position indicators during the surgery have different heights. You have also 4 millimeter and 5.5. And this makes it more easy for you to place the implant in a correct position. All pure implants, the monotype as well as the 2-piece implants, have the CLA implant surface topography. And if you remember the data from this morning, most of the studies that I have shown you dealt with the CLA implant surface topography. And for sure, regarding ceramic implants, this is the most often investigated implant surface topography that's available on the market, with a very high osteointegrative capacity, showing no differences compared to the gold standard in implant dentistry, the sandblasted and acid-etched titanium SLA implant surface topography. So a lot of people think that a monotype implant is something old-fashioned. They say, of course, probably this is based on the fact that in the last 2 decades, people have learned to work with a 2-piece titanium implant design because we're simply used to work with those implant designs. We have some advantages in terms of the flexibility of the prosthetic reconstructions. We have some flexibility in terms of being able to have reversibly screw-retained prosthetic reconstructions. But if you take a look at nature, we have no 2-piece tooth. The tooth is also 1 piece. And so in my opinion, this is the most natural way to replace a tooth. And even today's, in times of 2-piece implants, this is still a main part in our daily clinical practice to use a monotype implant, since in terms of aesthetics, especially regarding the anterior front teeth, the aesthetic results are really fantastic if you use the monotype implant. And this is the reason if the referral dentist allows us to use it, we still today prefer a monotype implant in the anterior area compared to a 2-piece zirconia implant, because simply the red aesthetics are better. They have a fuller thickness of peri-implant papilla formation, and so this is a very usable tool in your clinical daily practice. And I've integrated this slide a couple of minutes ago because this morning we talked about bone augmentation and monotype implants, transmucosal healing. Then you asked me about some studies, and here are some two examples where bone augmentation was investigated around transmucosal healing. And we know that a submerged and transmucosal healing shows similar outcomes when a simultaneous bone augmentation was performed using autogenous bone or also using artificial bone substitutes. And also in terms of regenerative procedures after infections around implants, there's also been shown that the regenerative procedures, also using xenogenic materials and a collagen membrane combined with a transmucosal healing, showed very successful clinical results. So This is something that has been scientifically investigated. So if you use a monotype implant, you have the data that confirms that it's possible. Of course, in very challenging cases, and in my opinion, it's more the fact that a lot of clinicians are more used to use two-piece implants. Maybe it's a little bit more easy for you in terms of the handling. But it's nothing that has to be avoided in every case. It's possible and scientifically proven. The monotype Straumann implant has two different diameters. We have a diameter reduced 3.3 millimeter implant, and we have a regular 4.1 millimeter implant. And the 4.1 millimeter implant can be used in any situation, so molars, premolars, anterior teeth. The diameter reduced implant is limited to the anterior teeth in the mandible and to the lateral incisors of the maxilla. This is not completely correct. So it's just the lateral incisors on the maxilla. And this is also a very important fact that you have to pay attention to when you treat your patients. Even though you have less bone volume in a molar area, it completely does not make any sense to use a 3.3 millimeter implant, in my opinion. If you have too less bone, you have to choose another philosophy, make bone spreading, bone augmentation, or whatever. But I wouldn't place a 3.3 millimeter implant in a molar area where you have a lot of chewing stresses. And by the way, I would also not use a titanium implant. And most of the titanium implant systems are also not recommended if they have a small diameter for the molar areas. By the way, this is nothing that is just specific for ceramic implants. So please pay attention to these indications. So let's have a look at the portfolio. We have different lengths. We start with 8, 10, 12, and 14 millimeters. Unfortunately, we do not have a 6 millimeter implant, so a shorter implant, and which is a pity because, especially in the mandible, we use a lot of 6 millimeters implants if you have not enough bone above the nervus alveolaris inferior. But so far, lengths from 8 to 14 millimeters are available. The abutments have different heights, 4 millimeter and 5.5. You have a complete portfolio that can be used or that is necessary for treating your patients, and that is also necessary for your dental technician being able to fabricate the implant-borne restorations. And the most important tool for me as a surgeon are the position indicators, because the position indicators can be used exactly like here you can see the depth gauges, so to check the position and the depth of the implant. And you see the abutment of the position indicator is exactly the same as the abutment of the implant. And this is really a very, very important tool during implant placement. And by the way, this is also something that we use around titanium implants, because the patient is able to close his mouth. So you have no problems in terms of the interocclusal distance when you want to check the implant position. And this is not always possible when you use the conventional used depth gauges. So let's have a look how we use it. This is a central incisor. You make the incision, pay attention to the papilla. You mark the implant position. If you do it old-fashioned, I always use a orientation stand to make sure that I'm not too much on the buccal, too far on the buccal side. I check the position using depth gauges. You see the patient can close his mouth. You check the position. Then you use the spiral drills up to the desired diameter that you want to use. In this case, we place a 4.1 millimeter implant, so we have 2.2, 2.8, and the last drill is 3.5 millimeters up to the desired depth. The implant has to be placed. Again, check the position. You see with this stand, the patient closes his mouth using the position indicator. Now we choose the height of the abutment. This is 5.5. The black one was 4.0 millimeters. Very important, even though it's a tissue level design, we have a bone level thread, so you have to use the profile drill since the implant is a little bit conical. It's very important. You remove the implant, place it. I place the implants with a hand. I check the implant position according to the ITI protocol. 1.5 to 2 millimeters below the exacted gingival margin, transmucosal healing. We let it heal for around about 2 to 3 months. You see, we have a provisional reconstruction, and then the next step is the prosthetic procedures. You see, after 3 months it looks like this. We uncover the implant shoulder by using these cotton ligatures that we press between the mucosa and the implant shoulder. Then there are instruments or components that makes it very easy to make a chair-side provisional crown to shape the peri-implant mucosa. After the mucosa has been formed, you take the impression and the final reconstruction is done, and we make this venting holes, as Ralph has mentioned. We use glass ionomer cement, very thin applicated in the crown, so don't use the gun and fill it up. And then you place the crown. You see the draining hole works pretty well. Then you wait around about a minute until the glass ionomer cement is initially cured. Then you use, the crown is already stable, then you can use a superfloss and remove the excessive cement around the implant shoulder. And this is still possible at this time point. If you wait too long, it's too hard. And this is much easier. You see here, the venting hole can very easily be removed. Then the patient closes again his mouth. You wait another 3 minutes, and then you have a very nice and controlled cementation process. So let's come to the two-piece implants. Compared to a monotype implant systems, of course, the design is different since we have no abutment that is firmly connected with the implant body. So we have the possibility for individual abutments, which widen the possibilities in terms of correction of the implant axis compared to the prosthetic axis. So we have, from a prosthetic point of view, of course, more possibilities to make a correction if the position is not an optimal one based on a bone defect or whatever. Nevertheless, it's important also when we use a two-piece zirconia implant, a prosthetic-driven implant position, backward planning, make an orientation guide, make a completely digital full guide using the static navigation system. So again, also using two-piece implant systems, the placement has to be prosthetically driven. Compared to titanium implants, the surgical but also the prosthetic procedures are more familiar compared to this, what we have learned to work with the last 2 decades. So there's, of course, some specific aspects that we have to pay attention to in terms of the material characteristics. For example, the high impression torques, because we have no thermal conductivity. But in terms of the handling, it's very familiar, as we know from the titanium world. With the two-piece implants, we are able to offer the patient screw-retained prosthetic reconstruction, so we can avoid the cementation process. But a screw-retained prosthetic connection brings other problems with this type of connection. So regarding the two-piece implants, it's even more important to pay attention to the manufacturing process and to the quality controls regarding the internal shape and the stability of the used components. But we've talked about this topic this morning. If we take a look at the data that is available so far, if we compare the one-piece implant design with the two-piece implant design in terms of the available data, there's no difference regarding the reported survival rates. Nevertheless, keep in mind, much more studies are available investigating monotype implants. So far, we just have a few studies that investigated two-piece implants, which is a drawback of two-piece zirconia implants in general. But I think, most of the companies have started to initiate clinical studies. The PURE system is just being investigated in a multi-center study in Basel and Zurich and Graz. We have performed 2 retrospective studies, including around about 120 two-piece implant systems. So you see, the data is currently being collected, and it's just a question of time when more clinical data on two-piece implants will be available. So let's have a look at the design of the two-piece implant. Again, it's a tissue-level design, which means that the implant shoulder is above the crestal bone, so it's not a bone level design. Again, we have a 1.8 millimeter transmucosal implant shoulder part that penetrates the soft tissue. And keep in mind, tissue level designs does not mean that the implant shoulder is EP gingival, you know. According to ITI treatment protocol, the gingival margin or the implant shoulder is 1.5 to 2 millimeters below the gingival margin, you know. If we go back to the standard shoulder, regarding the Straumann implant, then we have an EP gingival healing, you know. But standard plus is lower, so this is also something that has to be kept in mind, you know. Place the implant shoulder around about 1.5 to 2 millimeters below the expected gingival margin, and at least according to my experience, using tissue level implants, this is more difficult, you know. It's easier to place a bone level implant because if you're insecure, you place it 1 millimeter deeper to have more space for the prosthetic reconstruction. But with a tissue level implant, this is more difficult, you know. But again, the implant shoulder has a direct influence on the biological processes regarding soft and hard tissues. Keep in mind biologic width. So it's not always better to place the implant deeper because, you know, you do not place the implant in this moment. You know, you take care of the patient for 5 years, 10 years, and even more. And I think the deeper you place the implant, the higher is the chance that the patient gets problems later on. But of course, the depth has to be correct. There's nothing more severe than having an implant placed too high in the anterior area and the crown is too short. So this is really something. This is a task using the tissue level implants. So the design is exactly the same as compared with the monotype implant, but of course without the abutment, and of course with an inner design that is used to fixate the so-called pure base, so the prosthetic reconstruction. You see, we have a full metal, full ceramic implant, and the metal base, the pure base, is fixated into the implant body with a titanium screw. This pure base is also available in 2 different heights, and it's also possible to have an angled abutment, so you can place the implant a little bit more angulated to the buccal side, especially in the anterior teeth, the bone volume makes it necessary to place it a little bit more angulated to the buccal side, but it's still possible to have a screw retained connection on the palatal side. So this is also possible for this system. The indication, you know, the 4.1 millimeter implant can be used in every or in any indication, anterior teeth, premolars and molars. So we have no restriction in terms of the clinical application. And also the portfolio allows the complete treatment of all patients. The biggest difference compared to the monotype implant system is that we have a scan body. You know, for the monotype implants, there's no scan body available that can be snapped on the abutment. The 2-piece implant has a scan body, which makes it more easy to integrate the system or the 2-piece implant system in the digital workflow. The healing caps are made of titanium and nowadays also made of zirconia. So the connector or the surrounding peri-implant mucosa has no contact to metal components. So let's have a look at small surgery, premolar, the same drilling protocol up to the desired diameter. Also for the 2-piece implants, we use the position indicators. You remove the implant with a transfer piece made of metal. You place it in a correct position. You see here I combined it with a small bone augmentation. I use a resorbable membrane. We have the correct position. In this case, I had to use a titanium abutment. 3 to 4 months later, you remove it. You can use the scan body. You can make a scan using the scan body and send the file to your dental technician. He fabricates a screw-retained crown with a titanium metal base and a metal fixated into the implant abutment with a metal screw. You close it with a conventional way, just exactly the same way as you work with titanium implants. What is special around this implant type is, the pure base, and also this is very important for a dental technician. The Straumann company offers a special tool for the technicians that makes it easier to make the cementation process from the crown to the abutment. And you see, if your dental technician uses it, this is a special training is required before your dental technician can use or can work with this system, which makes it more easy to have an adequate sealing, in terms of that there's no gap between the pure base and the surrounding ceramic crown. So, thank you very much. And now I shift over to you, Andre.
Well, just continue on the pure one. You saw the portfolio, you saw the lecture before. I am a big user of these type of implants. I also, like Stefan was saying, I like the monotype. I like especially for the anterior area the 3.3 because the 4.1, even if it's screw retained, sometimes you don't have enough bone. So I like especially when the one piece and what Stefan was showing is that normally when we follow the protocol from Straumann, the primary stability of these implants is very good. Hand torqued, even if it's slow speed, whatever you want, you have to control well that torque because of thermal conductivity, and sometimes it's very easy for you to reach 35, 40, 45, and even you have that little piece that breaks to say that you're on a high torque, and then just go again and pass the burr, the countersink, so you can have a better, not such as a high primary stability. You saw this. It's very important that what Stefan was saying, although it's when we are with a one-piece implant, just be sure that you're on your correct apical coronal position with the soft tissue, and you can have get rid of that cement. I have the same, more or less same protocol that Stefan. When I'm going to cement, I do everything that I have in my power not to let the cement go in. So I'm very careful with that. But for the surgeon who's placing the implant and sometimes is afraid of that cement, just be sure that when you're placing this implant, you not stay shallow or above the gingival line. Okay, for a premolar is okay, but for a lateral incisor or a central incisor, it can be a mess. So be sure that when you saw the implant preparation bed of Stefan, this was what I normally see after 3 months of healing. I see a nice contour of soft tissue. I see a nice position, and it's what Jan's saying. If you go to our website, the escionline.com, if you go for the clinical cases, it's independent of the brand. You see the cases of Frank, of Jan's, of Stefan, mine, and you see always the soft tissue color and reaction to this type of material. It's very good. And this is what I normally see. That's what Stefan was saying. That's the natural part of it. I also agree. It's very natural. You feel natural when you see this. You feel very natural. The dental assistant feels very natural, and the lab technician also loves. The prosthodontics also love this compared to the titanium. So if everything goes according to what you plan, prosthodontic position, know where your tooth is, and then go from there. What Stefan said. You get the clinical result normally like this. The two-piece. This is one of my bloodiest pictures, okay? The two-piece, I also like the two-piece because I was born and raised with titanium implants. So for me, everything is screw retained, everything is two-piece. I like to have the prosthodontic flexibility. So when the two-piece was launched, I was very happy because I can do what I'm used to. Although, like Stefan said in the lecture in the morning, go to 35 newtons for torquing the final crown, or because of all the mechanical parts that were said. Normally, we had the possibility of having the titanium, screw closure, but now, like Stefan was saying, we have the possibility of having the ceramic healing abutments, which are very nice. Since the day of the surgery, we have the possibility of the gingival part is in contact with ceramic the whole time. I like also with the Straumann two-piece the flexibility, as you saw in the lecture, of having an implant that is fully integrated with the digital workflows of Straumann. So you don't need to change nothing on your daily protocol to place the ceramic implants. It's with the same software of planning. They have more or less the same insertion tools, the same kit, the same modus operandi as the titanium part. So you can basically do the same things that you use with the titanium. The connection part, as Stefan told, is a very stable one when you torque it down. Okay, so be sure that you don't forget to torque it down. And tomorrow we will have a Straumann PURE two-piece that we're going to make the live surgery of. One of the things that I like to use with the PURE is that the possibility that in the co-diagnostics is a Straumann software. The Straumann PURE has almost all the same features as the titanium, meaning that you can plan where your implant is. You already have in this software the line where it's supposed to be supracrestal, so you can plan where your implant's going to be in related to bone. So it's a visual tool that is very helpful in creating that situation. You can see all of these views, and also you can plan the PURE base that Stefan showed. I mean, you can change this for the highest one, the lowest one, and you can play with this. This is very useful because it's completely integrated with CARES and with all the digital flow from Straumann, meaning that Mariana, normally I tell which one that I'm going to use, and for these single units, she can produce the provisional crowns if it is necessary, or after 3 months, the final crown. But knowing from the beginning what will be the interocclusal space needed for this crown. So it's an implant that it's completely integrated in the portfolio. So you don't need to go and do extra. So tomorrow, this will be the case that we're going to perform. This is a 12 millimeter implant. It's a molar region. In these cases, the molar, I like to have the two-piece implant. You could go with the 4.1 one-piece implant. It's okay. Just don't go with the 3.3. I completely agree with Stefan on this. The 3.3 one-piece were made, as Stefan indicated, to anterior area. In this part over here, we are going to place the implant, and we are going to place a ceramic healing cap for transgingival healing. The protocol that we use, as you saw in Stefan's movie, it's the cylinder burst. It's not the flute ones. This is a straight implant, so it's like the tissue level, the titanium tissue level classic one. So that's the drilling protocol. The only thing that normally in these cases that I'm a little bit concerned is because this has a very good cortical bone. So normally you have to pay attention to this cortical, or otherwise when you're placing the implant, it just gets stuck with the high primary stability. So beware that you prepare and drill this situation. Then what we did is that I passed this information. So normally the workflow goes, the prosthodontist is the first one to reach the co-diagnostics. So the prosthodontist says, okay, the crown is here, okay? So Mariana and the digital lab, they take out the STL, they take the DICOM file, merge it together. The prosthodontist says the tooth is in here, and then I go in because I know where my tooth is, and from the position of the tooth, I can plan the implant. And then go. Go meaning that we produce the surgical guide, and the production of surgical guide is that I like to have some windows here to confirm the passive fit of the guide. Okay, I'm a window guy. I like a lot of windows. So I confirm the fit of this guide. I also, like Stefan mentioned, and as I mentioned in my lecture, digital guides do not save you from having problems during surgery. So you have to have your classic protocol and your teachings and your classic approach always there, because you will need them at a certain point. So in these cases, what I like to do is go for pilot drilling, because this is a molar. I have all the references in the world. I have the position of these, but I like to pinpoint the center of my rehabilitation. So what I'm going to do is that I'm going to place the guide, place my handle, and do the 2 millimeter drill, okay, until depths of implant placement. And then we take out the guide, and then we go classical. In this case, it's also good because, like Frank stated, if I do everything through the guide, you will not see nothing from the implant placement, not even the shoulder, because you only see the guide, okay? So it also has this education purpose for tomorrow. So this will be the case for tomorrow. So what we're seeing is that when we place all of these things, and someone asked today what is the average distance between things, that does this has an impact on the pink aesthetic score, and so on and so on. I think that's are going to be very good lectures in October in Zurich, in our main event. There will be keynote speakers speaking about that topic. So whoever interested in be there, just go, because we're going to have someone who's going to cover that for us. It was just a teaser for for October. And so this is my clinical experience with PURE, and I hope to see all of you tomorrow. Thank you, Stefan, also for making this brief introduction, and thank you.